I've been into clinical practice for the last 30 years, but what I'm seeing today is a trend wherein girls want to delay their age of marriage. Girls want to delay the age of conception, and one does not understand. But I want to highlight the main fact that a man can repopulate the world at the age of 97 or even 102. Evaluating the couple says that 50% of the responsibility is that of the husband and 50% of the wives. So what is the husband's or the male partner's 50% is first his ability to have sexual intercourse, and second is the quality of his semen. In 1 month, when your ovulation happens, you have only one chance to conceive between the 11th and 17th day. So give yourself that time to have that conception and plan your intercourse at least 3 times a week before you say that you are having a problem conceiving. We also ask her whether she has any problems with sexual intercourse. You will be surprised that we have couples who have unconsummated marriages for almost 6 or 7 years. They have not actually had a penetrative sexual act. One, either because of a fear of anything going up the vagina, which is called vaginismus, seen in 7% of the female population. Very simple. We counsel them, we make them go through behavior therapy, and seldom do they need any sort of operative intervention. When I sit down and counsel the couple, it all gets sorted very well. Hi, I'm Dr. Ranjana Dhanu, back this time in order to discuss problems of fertility amongst young couples. So today, the problems that we encounter as far as fertility planning are very different compared to what we saw 20 years ago. I've been into clinical practice for the last 30 years, but what I'm seeing today is a trend wherein girls want to delay their age of marriage. Girls want to delay the age of conception, and one does not understand. But I want to highlight the main fact that a man can repopulate the world at the age of 97 or even 102, but a girl is born with a limited obstetric career. So from her menarche up to the 30th year is her maximum period when she has her optimum ovarian tissue. And so I always say that childbearing should be ideally between the 25th or 26th year up to the 32nd year if possible, because after that is when the ovarian function starts to decline. But let me just first tell you what I normally tell a couple who comes to me anxious to conceive. So I always tell them that 50% of the responsibility is that of the husband and 50% of the wife. How do we define infertility? So infertility is defined as inability for a couple to conceive after a period of 1 year of uninterrupted sexual intercourse, which means without using any form of contraception, when they are having the penetrative sexual act, and she is unable to conceive even after 3 intercourses per week for almost a year, of course avoiding any form of sexual activity during the menses, then I say we need to start evaluating them. So evaluating the couple says that 50% of the responsibility is that of the husband and 50% of the wives. So what is the husband's or the male partner's 50% is first his ability to have sexual intercourse, and second is the quality of his semen. So these two things have to be studied. So whenever the couple comes, when I ask them about the coital frequency, I'm surprised because they say, "Doc, we are tired, we are fatigued, or he's traveling or I'm traveling, and these are the issues that I see currently." So please understand, before you see any consultant, try and increase your incidence of sexual intercourse before you actually brand yourselves as a couple unable to conceive. You're not giving yourself that fair chance, because in 1 month, when your ovulation happens, you have only one chance to conceive between the 11th and 17th day. So give yourself that time to have that conception and plan your intercourse at least 3 times a week before you say that you are having a problem conceiving. The next thing is whether the husband has an issue with either premature ejaculation or erection or any other issues, and also then to get his semen tested. So there is a certain standard procedure which is advised to the male partner, wherein after 4 days of abstinence, he has to go and get a semen test done, preferably by going to the lab and giving the semen by a method of masturbation. Because if you take the sample from home, heat or cold can denature the sample and give us an erroneous report. If it is more than 4 days of abstinence, then I request the couple to first see that he ejaculates and wait 4 days and then do the test. Less than 4 days can reduce the amount of sperm in the sample. One erroneous sample does not mean that he has a problem. We will have to then evaluate him further by repeating a sample or sending him to an andrologist. An andrologist is a male doctor who actually looks into the physical problems of the male counterpart in a couple in order to see why he is unable to conceive. Now we come to the female counterpart, and what is that? So first we take a look at her general physical well-being, whether she has any any issues like anemia or thyroid or any other hormonal problems, and then we come down to looking at her private parts, which is her uterus, tubes and ovaries, first on a sonography. We also ask her whether she has any problems with sexual intercourse. You will be surprised that we have couples who have unconsummated marriages for almost 6 or 7 years. They have not actually had a penetrative sexual act. One, either because of a fear of anything going up the vagina, which is called vaginismus, seen in 7% of the female population. Very simple. We counsel them, we make them go through behavior therapy, and seldom do they need any sort of operative intervention. When I sit down and counsel the couple, it all gets sorted very well. Or it could also be other issues wherein the husband and the wife do not have adequate time, or maybe selective impotence, or impotence where the husband loses his erection very quickly. So after getting rid of all these issues, and when we start to allow them to have a natural intercourse, we advise them then to go ahead and plan naturally, of course taking certain preconception vitamins like folic acid and B complex. And still, if they cannot conceive, we evaluate them further. So what are the evaluatory factors in a girl? Clinically, when I see her, I look at her whether she has any acne, whether she has any hair growth, because and there are so many videos that you all must have seen on PCOD, though I'm going to, in my future videos, also going to talk in detail about PCOD. So clinically, when I look at a girl and I see little acne on the face, or a little oily distribution or oily facial texture with a few hair on the chin, when I ask her whether there's any history of any developing any hair or growth of any hair around the areola of the breast or below the navel, this typically suggests polycystic ovarian disease, and she needs to be evaluated further for any hormonal imbalances, because we do know, as a thumb rule, PCOD could be related to either prolactin or thyroid excess. So if that is corrected, and if she's got to ovulate well, because we do know PCOD is a problem of chronic anovulation, a simple correction of PCOD with diet, weight loss, lifestyle modulation, exercise and certain tablets being given to make her ovulate can easily make a couple conceive. So that's a very logical thing about the most common problem, which is PCOD, wherein a patient could have irregular periods, a little bit of excessive weight. Again, I insist that when I do a detailed video about PCOD, I'm going to explain all that to you, because I have a lot to cover for you as far as female factors for infertility are concerned. Coming to the next problem, and that is typically looking at structural abnormalities of the uterus. So there could be a problem with fibroids, and typically fibroids are muscular growths that start off in the muscle wall. They could be one or multiple. Talking about structural abnormalities of the uterus, wherein there could be a mechanical barrier. If you take a look at this particular picture, fibroids usually start off in the wall of the muscle. They could be one or multiple. They start off with growing here, but they can migrate to the surface or go into the cavity. So typically, if a fibroid enters the cavity, it's going to occupy the space where a baby has to grow. So it becomes like a mechanical barrier. So that is something that needs to be dealt with. Or any fibroid that is closer to the tube, or if it is on the lateral aspect of the uterine wall, this all can interfere with the tubo-ovarian relationship and implantation, wherein the egg and the sperm, even if they meet, there is no place for the embryo to implant, and that is how these mechanical barriers can come into the way of natural conception. For a couple to understand that fibroids almost always do not cause fertility issues. So every fibroid does not cause infertility. It is only those patients who have had an inability to conceive, because I have had patients who have had fairly large fibroids who have come to me in pregnancy. We've delivered them and tackled the fibroids after delivery. So only if a couple is having a problem conceiving after ruling out all other problems, or if she has had a mid-trimester miscarriage wherein in the 16th or 17th week she has had a miscarriage, then those fibroids need to be addressed as a part of the infertility workup. So it's very important to understand which patient is to be individualized for treatment of fibroids. There are also times when a patient can have a tubal block, or she can have a previous tubal pregnancy wherein she has lost one of her tubes. So there she becomes only a 50%, she has only a 50% chance of natural conception. So these girls again need to be guided, but because she has had a previous removal of a tube, and that too laparoscopically or with an open surgery, it is important for us to identify whether there are any adhesions around the tube and ovary, which is a normal ovary, because you have to respect the fact that she has very limited number of eggs for natural conception, and hence a laparoscopy with a hysteroscopy should be done to study the uterine lining with the other tube and the ovary. So this is some of the aspects in which I am talking about tubo-ovarian relationship in relation to fibroids, or with a previous ectopic pregnancy where she has, or a tubal pregnancy where she has lost a tube. Now one more very common issue could be an ovarian cyst of endometriotic origin. So what is endometriosis? Endometriosis typically is finding uterine lining, active uterine lining tissue other than the uterine lining on other surfaces, which could be on the ovary, or it could be on the posterior surface of the uterus, which could be here on the uterus sacrals, or forming adhesions with the bowel. This is only when the endometriosis is limited to the pelvis, but once it gets out of the pelvis, it could go on to the abdomen and also into extra abdominal sites. So it almost behaves like a cancer, but is not a cancer. Understand that endometriosis is progressive, it is recurrent, it is debilitating because it is associated with pain as well. Another variant of endometriosis is adenomyosis. And what is adenomyosis? This pink lining starts to invaginate into the muscle wall, and it grows there and it bleeds over there. So that causes the uterine wall to become thicker. That makes it less receptive for the egg to be implanted. Adenomyosis along with endometriosis could also become a problem with tubal transport and implantation issues for the embryo. And adenomyosis can be diffuse or focal. So focal adenomyosis is just like a little mass on the posterior surface of the uterus, one of the most painful conditions in gynecology, wherein the patient says, I have excruciating and stabbing pain in my pelvis, doctor. There are different tests available to identify the severity of adenomyosis with blood tests and an MRI and a sonography, a dedicated ultrasound Doppler, which tells us the degree of severity, and depending on that, we can offer either drugs or surgical assistance in order to take care of this. Our whole intention is to see that we are fertility enhancing in our approach when we're trying to gather this architecture back to normal in order to see that she can conceive naturally. Other issues associated with infertility could be infections. So there could be pelvic inflammatory disease, or there could be history of tuberculosis. So there are all different evaluations that need to be taken care of. The main problem that we're seeing today is because girls are not finding their right partner, they are going in for a delayed age of marriage. But I advise all of them to go and see their gynecologist and speak about the option of egg freezing, because after the age of 32, as your eggs start to reduce in quality and in quantity, it would be difficult for you to conceive later. So that is when girls are opting for now egg freezing or embryo freezing if they found the right partner, but they are not in a financial capacity or social capacity to have their child, then they can freeze their embryos as well in order to see that they can conceive, or they can plan the pregnancy at a later date. Do understand that women do have a little limited scope as compared to men. I said this in the beginning of my talk as well, that a man can repopulate the world at the age of 100, but a woman, if she starts to plan her childbearing after 35, because of the aging of the eggs, there's a problem with chromosomal defects, very commonly seen as Down syndrome. So one has to evaluate after she gets pregnant whether to see whether she's suffering from the fetus is suffering from anything like Down syndrome or any chromosomal defects. Also, after 35 years, the chances of instrumental and complicated deliveries, abortions starts to go high. So my main advice to most of the couples who are anxious to conceive or who are married need to understand that there is a certain time frame. Do not procrastinate. Time yourselves accordingly. Have a natural intercourse at your regular intervals that I have explained to you, and if after 1 year you do not land up conceiving, please go and see your gynecologist for further advice. With that, I end this talk today, and we're going to talk in detail in our future videos about each individual malady which leads to infertility in women. Thank you.